All right, let's get started. Hello, everybody. Thanks for joining us. I'm Maren McKenna. I am a journalist and author and a senior fellow in Emory's Center for the Study of Human Health. And this is one of our episodes in Emory's author Q&A series, which I'm now going to have to cough about. I'm so sorry. I am absolutely thrilled to be talking to the person who is visiting us today. This is Dr. Perri E. Klass, who is a professor of journalism and also of pediatrics at New York University, and just a longtime hero of mine, and author of memoir, of incredible nonfiction works, of instructional books, and also of fiction. She is insanely productive. And I can't wait to ask her questions about this. But we are here primarily today to talk about her new book published last fall, A Good Time to Be Born: How Science and Public Health Gave Children a Future. Perri, thank you for zooming into this chat.
It's my great pleasure. And I should just say that this is an opportunity for me to be interviewed by one of my heroes. So very excited to be
So
here.
this is our Mutual Admiration Society.
Yes, absolutely.
I'm absolutely thrilled. Okay, so gosh, where to begin? I think what we should start with for the members of the audience who are younger is, if you don't mind giving us a little bit of a bio, essentially how you got to be where you are, being a physician and a professor of journalism and a practicing journalist and a novelist and so forth. That's a lot. How did you get there?
Well, fortunately, I can be honest, and I can admit that this was completely unplanned and that I had no intention of doing any of this, and that it all just happened. And I say that because people now who want to study medicine or public health or nursing and write often come to me or get sent to me to ask how to plan it out properly. And I have to try to pretend that there's a way to plan it out. So what happened to me was, first of all, I grew up with a writing mother. My mother was a writer all her life, and she was a writing teacher. She taught writing at Manhattan Community College. She loved teaching writing, and she was what you would call messianic on the subject. If she met you and she thought your story was interesting, and she probably would think your story was interesting, and she thought your voice was interesting, and she probably would think that, she would say to you, you have a book that no one else can write. You have a story that no one else can tell. And I think that I grew up in a house in which people felt about writing, my mother certainly, but also through her influence, my father was an academic, but also a writer, that it would be like, if you think about growing up in a very musical family, and mine is a very unmusical family, but if you think about growing up in a very musical family, you might take for granted that any child should grow up with music, should grow up playing an instrument, should grow up with the skill, because otherwise the world would just be a poorer, flatter place for that child. And it wouldn't necessarily be about making your living as a musician. So I think I grew up feeling that way about writing, that writing fiction, telling stories was part of how you live in the world, how you enjoy the world. But my mother was also very, very, very clear that a writer needed a day job. So, I went to medical school because I was a biology major in college. I thought I would be an evolutionary biologist and study parasite host life cycles. Then I realized I really was more of a dilettante and not a researcher, but I loved biology, and I had been a biology major in college. And the only things I ever did in college were take the biology major pre-med courses and take creative writing workshops. So I went to medical school wanting to be a doctor. And I thought these would be two separate things, that I would be like being a doctor who played the violin. I would be a doctor. I was serious about being a doctor, and I would write fiction. And when I was in my first year of medical school, a magazine, which had just bought the first short story I had ever sold, which was the most exciting thing that had ever happened in my whole life, they knew that I was in medical school, and they asked if I'd write about it, what it was like being a woman in the first year of medical school, which in the early 1980s was a little more unusual. And I had to figure out how to do that, how to write nonfiction, how to write personal stuff. Did very badly, offended a lot of the people I went to medical school with without meaning to. Got it wrong from the point of view of the editor, a story I can tell if you want to know, but kind of realized that this world I was coming into, this medical world, was a closed world full of really interesting stories, and that people would find those stories worth reading if I could learn how to tell them.
So there's a little bit, I think, that you've left out of that history, which was that at the time that you were in medical school and you were beginning to learn how to be a writer, you were also a new mom, right? You had your first child when you were in med school?
I had my first child in my second year of medical school, and that was actually the first query letter I ever wrote, in that I was taking, in the first year of medical school, the sort of the truism is you learn how the normal body works, and then in the second year of medical school, you learn everything that can go wrong. So I was sitting there in my reproductive pathophysiology course, learning, I was pregnant for the first time, and I was learning absolutely every single thing that could go wrong, from small disasters to the big disasters, to the rare, you'll never see this, it would be one for the history books, but it is recorded disasters. And then in the evening, I was going to this childbirth class in which we were learning to breathe and, how to insist that everything be done as naturally as possible. And I wrote a letter. This is back in the year. I wrote a letter on my typewriter on paper to the editor of the New York Times Magazine saying, this is really weird. I'm a pregnant medical student and there's no overlap between what we learn in reproductive pathophysiology and what we learn in childbirth class. It's completely different. Could I write about this? And they let me write about it. And that was the first time that I had ever actually kind of looked at my own life and thought, this could make an interesting story.
So let us fast forward a couple of decades.
Yes.
You finished medical school, you finished your training, you are a credentialed pediatrician and a professor in a medical school, and you are a professor of journalism. And as we do, as teachers of journalism, you now have written multiple books. And what I'd really like to hear about is sort of like how this book came about. I have many things to say about the book, but I'd like to know first just sort of why it exists. So was there a particular inciting incident or thing that happened that made you want to write this now?
Well, it's not like anything else I've ever written. And I spent most of the time I was writing it feeling desperately out of my depth, which may be a good sign for a writer. It may be, the way that you're, growing or pushing your own limits. But, well, to be honest, I've been teaching a class every January for the last 7 years or so on children and childhood. And it's been a class that I've co-taught with my husband, who's a historian and has done a lot of work in the history of childhood. And it's an undergraduate intense January term course in which we try to bring together the history of childhood and of how people have thought about children, and the biology and the medicine of how people have thought about children in childhood. And the point of overlap we had realized was the idea of what it means to say that children are not small adults. And that's something that historians think about, how childhood is recognized and understood, how people come to understand that children are not just small adults. And of course, it's the basic truism in pediatrics. You hear it over and over again in everything from how to do a physical exam to how to dose medications to how to understand development. Children are not small adults. And so we tried to put those ideas together. And one of the questions which came up again and again in the course was, what does it mean that up to about 120 years ago, pretty much everybody lost children? What does it mean historically, culturally, emotionally, medically? It kept coming up because up until about 120 years ago, there just wasn't anything you could do to prevent most of the infant and child deaths that happened. And I'm talking in the 19th century, in the 18th century, but also in the 13th century. I'm talking all the way back. And parents, and I started to think about how the time that I trained as a pediatrician, the second half of the 20th century in a reasonably wealthy country, it's actually unique in human history. We were trained in the idea that no child should die. And that if a child did die, either there was something that medicine hadn't learned how to do yet, right? It was something to still be conquered, or else there had been a lapse. The safety wasn't perfect. The accident prevention wasn't right. The car seat, the sleep position. And that view that essentially barring exceptional tragedies, that every child born should live to grow up, that parents should be able to look at their two children or their three children and expect to see all of them grow up, that was so recent. And I became a little bit obsessed with the question of why we don't note, celebrate, and discuss this incredible change as parents, as pediatricians, or even as a society. And that's where the book came from.
So I'm really intrigued to know more about that course, but I'll ask you that in a minute, because I wanted to talk about this, how your book looks at this unique moment in history. Just the opening lines are so powerful. Our grandparents and great-grandparents and all the parents before, throughout history, expected that children would die. It was a known and predictable risk that went along with being a parent. Now we expect children not to die. That was so resonant for me. I should make clear to people who don't know me in the audience, I am not a parent, but that was so resonant to me as someone who I guess qualifies as a historian of antibiotic resistance. Yeah. I talk to people very frequently about how unusual this moment is in human history, that we are protected from and can cure infections, and that back as recently as the time of our grandparents, if you're the age that you and I are, then that was not the case. My grandmother was, both of my grandmothers were born before the beginning of the antibiotic era, if you count it from, the rolling out of penicillin in World War II in 1942. And that sense of the fragility of life from just even minor injuries becoming infected is something that we have completely lost. And it's really striking to me that it feels to me like we've also completely lost this sense of childhood, and particularly infancy, as being a uniquely perilous moment. So I'd really like to hear, with that very long introduction, talking about myself, I'd really like to hear a bit more about how you sort of thought your way back into that, and how you sort of strategized to bring the audience of the book back into this time when simply existence as an infant and a child was a profound risk.
Well, I think that what you were talking about with the antibiotic resistance, and just the magnitude of what antibiotics meant, and I don't know if you think there are people who've written about how the culture reflects the advent of antibiotics. I've thought about this sometimes, because I sometimes, with my pediatric eye or my infant mortality eye, I look at, say, classic movies from the 30s in which a child gets pneumonia and, fights for her life or dies or is miraculously saved. But I mean, I don't know if you think there are people who've done, did the culture reflect that and celebrate it when antibiotics came along? I mean, we think about the celebration of the polio vaccine, right, in the 50s, when the trial ends and it turns out that the polio vaccine works, and, church bells ring and it's front page news and the country is celebrating. Do you think antibiotics were celebrated in that same way, or understood in the same kind of game-changing way?
I think they were understood, and they were celebrated in the sense that there was a vast, crazy enthusiasm for them. There is supposedly in the collection of it's the British Museum, or maybe the London Science Museum, there's a lipstick preserved that had penicillin in it. Because of course, when penicillin, the first of the actual antibiotics, first arrived, it wasn't a prescription drug. Wasn't made a prescription drug until the 1950s, and that was because of allergic reactions. So it was effectively an over-the-counter drug, and people could put it into anything, and they did. So there was this crazy commercial enthusiasm for them, which Alexander Fleming, of course, watched with complete horror, because he knew what would happen to his drug if we overused it, and he was exactly right. But the sense of what's on the far side, or maybe on the what precedes what you're talking about, were you able, as a physician who's also studied medical history, how were you able to think yourself back into that sort of landscape of risk in which?
I don't think I can. Mm-hmm. I think it's one of the things which divides us from people who came before, the ways the ways, and I think this is also true for me as a pediatrician, people go into pediatrics nowadays in part because, if you'll excuse me, it's a happy specialty. Even pediatric oncology, 80% or more of children who get cancer recover. And when we say recover, we mean grow up. We mean, go on to live long lives. That doesn't mean there isn't tragedy and there aren't bad stories, but there are an awful lot of good stories. If you think even about high acuity specialties like neonatology, most children make it. And if you're in general pediatrics like I am, so we kind of shoot for 100%. 100% of the kids who come to the pediatrician are supposed to outgrow me and go on to see an adult doctor. And of course, when you're in adult medicine, you have exactly the opposite. In adult medicine, every single one of your patients will eventually die. And your job is to, cure disease and prevent suffering, but also to think about what happens at the end of life. Not in pediatrics. We think in terms of, everybody should graduate and, goodbye, send us a postcard. And on the other hand, when I read the words of people who were taking care of children as recently as the time that my parents were being born in the 1920s, those doctors were, every year there was a polio epidemic. Every summer there was a summer diarrhea epidemic and 1,000 babies died in the neighborhood. They were accustomed to a level of vulnerability for infants and small children, which honestly, I don't think I get moments as I read their words when I can imagine it, and or I think I can imagine it, but I think it's very hard for us to imagine that. And I think it's really important to say that when I read the ways that parents in the early 20th century or the 19th century or before write about their children and write about losing children, it's clear that they love their children just as much and they love them in the same way. But it's also clear that it's part of the job is to love somebody whom you may not be able to keep with you.
I used to live in a town north of Boston that is a very, very old town. The tombstones in the cemetery go back to something like 1631. And there are rows of family tombstones, and sometimes there'd be a row and the name would just be Baby. Yeah. Baby, whatever the names were in that town, Baby Jones, Baby Cuthbert, not with even a first name. And it was so obvious that infant mortality at that time was, though the children were obviously being memorialized, it was so extraordinarily high that it was almost sort of expected in a way.
Almost expected, or certainly I think you knew. And I think this would have been true in the 1920s in Brooklyn when my grandmothers were having their babies, my parents. I think if you went around the table, everyone at the table would have lost a child, lost a sibling, would remember times in school when a child got sick and didn't come back. It was part of everyday life. It had to be. And one of the other sides of that, which I have to say, is it didn't matter if you were rich and powerful. I mean, it's always been better to be rich than poor and better to be powerful than powerless, but their money did not protect you. And I think that's another really interesting and really important part of this picture, is that it actually was something which cut across socioeconomic status, which cut across race and ethnicity. Nobody had a way to keep a child from catching diphtheria. Nobody had a way to save a child who caught diphtheria.
I want to talk in a minute about how this started to get better, but just a bit of housekeeping first. So to everyone who's listening, I can see the participant numbers ticking up. Thank you all for coming. You can ask a question at any time by typing your question into the Q&A block. This is a Zoom webinar, which means that you won't be able to ask us a question by actually appearing on camera and voicing it. You have to type it into us. I am going to get to your questions later in the hour, but you can put it in at any time if something that we are talking about prompts a question. Don't be worried about having to wait until 4:30 or 4:40 or something like that. So, returning to our conversation. Before we get to the achievements of public health, A thing that is really remarkable to me about the book is the way that it melds both medical history and social history with a really profound, sampling is the wrong word, but with a profound knowledge of the literature and also fiction of around the childhood experience and child death. And I'm really, maybe this came out of the course you were mentioning, but I'm curious how you gathered all these pearls from the 18th century, 19th century, where this profound acquaintanceship with the literature of children dying and being memorialized came from.
Maren, I'm seeing a note that some people are having trouble with the audio. I don't know whether there's something that you can, your end, and I don't.
I do not think we have control over this. I recognize I can hear you and you can hear me. And if others of you are having difficulty, so another person is saying he can hear the audio. All right, everyone else is saying sound is fine. I'm sorry, Jonathan, it must be your connection. We apologize. Thank you all for checking in. Okay. So let's go back. So this profound acquaintanceship that you have with the literature of child illness and child death, where did that come from?
So I have to, let me just say that one of the things which is really interesting about medical training, and I'm sure it's also true for other kinds of professional training. I'm sure it's true for nursing. I'm sure it's true for other kinds of training. It changes you a little bit as a writer, or more than a little bit, and it also changes you as a reader. I have a disgraceful habit now of reading great literature for diagnoses. Yeah, but what has he got? But why are you doing that? And I do it even sometimes in ways which really gets in the way of my enjoying the story. But what I found was that over the last decade, as we were teaching this course, as I was thinking about this, I kept finding places where it seemed to me that the ways that children's death appeared in fiction, in poetry, was again reminding me over and over and over that this is just common. This is just part of life. And so, for example, I got very interested in the question of the way that the death of children turns up in children's books, classic children's books, books like Anne of Green Gables has a scene in which Anne, when she's 10 or 11, her friend Diana comes and gets her in the middle of the night because her little sister has terrible croup and seems like she's going to die. And Anne grabs the bottle of Ipecac and goes out in the snow, and they take care of the little girl all night. And they just, well, everyone in the story takes it absolutely for granted that, yeah, a child might get bad croup and die. Good thing that little red-haired girl at the Cuthberts knew what to do. But it's a sort of an adventure, and then you turn the page, and it's another adventure. Or in Little Women, when Beth gets scarlet fever, and there's the possibility that she may die. Just the ways that even in books written for children, this was so much a part of life, that there were diseases out there that could suddenly strike and nobody could do anything about them. And that's a part of life, but it's not what the book is about. And I was very interested in this with children's literature because I love children's literature, but also because nowadays, if you wrote a book in which a child caught a disease and died, it would be a problem novel. That's what the book would be about. It would be about dealing with it and how the family reacts and going on. That's not what Little Women is. That's not what Anne of Green Gables. This is just one of the things that can happen in life. And so I was just collecting it. It just kept sticking with me as evidence of kind of this lost world. And once you start looking this way, once you start looking, for example, in paintings, or as you say, in memorials and in graveyards, you sort of start to feel that there's this shadowy army of lost children standing by all through history in the corners of the paintings, or in the monuments, or in the poetry. And we've sort of lost our connection because we now, again, are on the other side of this incredibly fortunate divide.
There's that shocking moment, except it may not have been shocking to them, in the Little House books. I forget which one it is, but in the juncture, sort of in the juncture between two of the Little House books, it's either it must be measles. sweeps through the town, and the older daughter is recovers but is blind.
Well, interesting you should bring that up, because in the book, it's said that it's scarlet fever. And a couple of years ago, there was a medical student who wrote an article because she remembered this, that Mary goes blind in the Little House book, supposedly because of scarlet fever. And she offered that somebody, she was in medical school, and they said, what are the possible complications of scarlet fever? And she said blindness. And the teacher said, no, that can't happen. So she actually went back digging to see if she could find historically what Laura Ingalls Wilder's sister had, and was able to find evidence that it was probably encephalitis rather than scarlet fever, but suggested that maybe she used scarlet fever because it was such a familiar but dreaded illness that it was an easy one to name. So there's actually a whole interesting small literature on that. But yeah, absolutely. She went blind because sometimes little girls get sick and they go blind.
And the story rolls on, and she is not the main character. I mean, she's sort of she's a thing that sets something in motion for the protagonist, because now the protagonist has to be a teacher, but it's not as it would be in the modern era. I mean, not that those books are this old. It would not be the travails of the blind girl. It's just, she's just part of the scenery.
And in fact, she did, Laura Ingalls Wilder did earn money and sent her sister to a college for the blind, and her sister did get training, which was not, necessarily easily obtainable everywhere at the time. And but all of that was just very much kind of, this is what happens. But say there's also in Five Little Peppers and How They Grew, all the children get measles, and Polly Pepper's eyes are endangered because measles can cause blindness. And she's terrified that she's going to be blind for the rest of her life, and she has to wear a bandage over her eyes for the whole chapter. And then eventually the bandage comes off and she gets better. And in the next chapter, it's, the adventure of trying to make the birthday cake.
So now let's talk about the content in your book. As a writer, I am obsessed with structure. I think we talked about this when I talked to your class, and the structure of yours is a pretty sort of straightforward chronology from things starting out pretty bad to things getting better. But the thing that makes it fascinating to me is that there are sort of, I don't know if the right word is tent poles or milestones along the story, and they are all female doctors who in some way stepped into this problem of infant and child mortality and made it better, even against opposition from the male establishment. I was astonished that the American Medical Association, in one of your early chapters, opposes child and maternal health centers as socialized medicine in 1921. Yes. I think they're still speaking from they still have the same script today about socialized medicine for other
not
things.
Their moment of glory. It was not their moment of glory, and there was actually a break with the early organized pediatrics people who were much more socially conscious as a group, although not all of them, of course. But so that's probably, this could be a much, much bigger book. There's so much that this is one of those books where every chapter you feel could be a book, and in some cases is a book. In some cases there's, a brilliant book on the infant mortality campaigns of, the early part of the century by Richard Meckel called Save the Babies. There's a brilliant book on diphtheria by Evelyn Hammond. Each of those subjects is so big and so complicated. So even as you're choosing your subjects and you feel that you're not really doing each of them the kind of justice and detail they deserve, you also choose your characters. And there are plenty of interesting characters, because that this happens is, it's public health, it's medicine, it's science, it's research, and you can't tell it all. And what I found myself, I think, probably identifying with some of the early women doctors. I found myself struck by the way that many of them actually did go for a public health approach sooner rather than later. But I also found their words, their memoirs, their diaries, interesting reading. And in some cases, for example, I write about Mary Putnam Jacobi, who was married to Abraham Jacobi. He's usually thought of as the the founding father of American pediatrics. She was also a doctor. She did the diseases of women and children. And one of the points that I'm trying to make is that even with all this expertise, he wrote a massive treatise on diphtheria in 1880. He probably knew more about diphtheria than anybody in the world, had probably treated more patients. She knew more about women and children's health. But when their two children come down with diphtheria in 1883, there is not anything, just as I'm saying, even if you're the richest person in town, even if you're the most knowledgeable doctor in town, there's not necessarily anything you can do. So that when, and their son dies of diphtheria. And so, you know, for me, that was, she's a wonderful writer and letter writer and diarist. And I enjoyed sort of reading her way through medical school with her. But I guess I was also sort of thinking about the many different levels of identification of, you know, as a doctor who takes care of children, if you have children of your own, you always construct little barriers in your mind that the bad things that you sometimes have to see happen to other children are not going to happen to yours. And so I allowed myself to think that I probably understood some of the emotional content and was interested in trying to understand more of it.
So a thing that's so interesting to me about this history is that when we start, as we've talked about, infant and child mortality are just kind of taken for granted, even though they are a source of grief. And as medical knowledge grows, this infant and child mortality is sort of consigned to the sphere of women who carve out agency in becoming doctors. You mentioned the doctors Blackwell, the two famous sisters, who by their efforts sort of force infant and child mortality and the improvement of it into the mainstream, into something that is something that should be considered by all of medicine. And that that sort of levering of the concerns of women and children into the male medical establishment is just, it's really powerful.
Again, I don't know if we're being completely fair to, you know, a lot of the men who are part of this as well. But I do want to say that, say, if you read the book, there's a woman I write about. She's quite an extraordinary figure. Her name is Rebecca Lee Crumpler, and she's the first African-American woman to earn a medical degree in the United States, at the New England College, in the middle of the 19th century, and she has an extraordinary career. She practices both in Boston and also in Virginia right after the Civil War. She decides to go down to Virginia and practice in a large population of formerly enslaved people who are being whose care is supposed to be being managed by the Freedmen's Bureau. And so she has this extraordinary range of clinical experience, North, South, Black, White. And she writes a book called, she writes a 2-volume book called A Book of Medical Discourses, in which she talks at great length about, again, you know, as a doctor, you read this and you think about all the babies she's taken care of who didn't make it because there's nothing she can do for many of the diseases that she's writing about because there are no antibiotics. And, you know, much of her advice is very good. Her, you know, breastfeeding and hygiene and keeping the babies, you know, warm when it's cold, but there are limits. And so you think about all of the children who don't make it, who she has to watch die. But one of the things that she says in the book is she talks about how clearly there were a lot of male doctors who weren't very polite to her. And she says are not very polite to women doctors ever, but will allow them the care of children, will sort of admit that that's a place they belong. And then she goes on to say, but what could be a more important job? You know, this is actually the most important job there is. And you know, her words really resonate. The other doctor I write a lot about is a doctor named Josephine Baker in New York, who trains at the end of the century, and she's drawn to public health, and she's very involved with the question of what you can do about those thousands of babies who die every summer in the, you know, 1916, 1917 era? How can you keep them from dying of the summer diarrhea? And again, as with Dr. Crumpler in the 19th century, Dr. Baker is working without antibiotics. She's working without rehydration therapy for children who get diarrhea. She's working with hygiene, sanitation, good sense, teaching parents, just as Dr. Crumpler was. And I find that really inspiring and also really interesting. And Josephine Baker writes about the fact that in medical school, she's made to take a course on the normal child, and at first, which is taught by another early female doctor, and that at first she's outraged. Why do you need to study that little pest, the normal child? That's not why you go to medical school. But she writes about how much she takes away from this other woman's teachings and from thinking about the development of the normal child.
So I'm really glad that you brought up Dr. Crumpler, because that gives me a segue to something else that I wanted to ask you about the content of the book, which is that you're very clear throughout to talk about the mainstream experience of infant and child health, and then how infant and child health is different for minority populations, primarily for Blacks and African Americans. And there's even I mean, we can see this even today. You point out how different infant mortality shockingly remains in the United States for Black and white children. But all throughout, there's this sort of sense of you're referencing the ways that society at the time thought of white and Black children as being differently valuable, going back into slavery times, and in ways in which white mothers might be held up for taking care of their children, but Black mothers would be blamed for taking care of them insufficiently. And can you tease out for us a bit more what the racial tensions are in this story of child health improving?
Well, one of the things which is striking about now, so if I say to you that at the beginning of the 20th century, more than we measure infant mortality, as I'm sure many of the people listening know, we measure it by how many children out of every 1,000 live births don't live to their first birthday. So it's death, born alive, but not alive at the first birthday. So just to be clear, at the beginning of the 20th century, in 1900, 1910, that's more than 100 out of every 1,000 live births. More than 1 in 10 of the children die by the first birthday. And of course, that does not count the children who are going to die when they're 1 or 2 or 3 or 4 years old from any of the things that we've been talking about: scarlet fever, diphtheria, diarrhea. But so it's 100 out of every 1,000. And now, just to give you context, it's a little under 7 out of every 1,000 who don't live to the first birthday. So that's the change across the 20th century, from more than 100 out of every 1,000 to a little under 7 out of every 1,000. What I want to say is that it is now infant mortality, the rate of children not living to the first birthday is twice as high among Black children as among white children in the United States right now. So we're talking about a rate that's somewhere around 10 versus a rate that's under 5 for Black versus white. That ratio holds true going back to a time when you're talking about 250 out of every 1,000 versus 125 out of every 1,000. That is to say, the actual numbers get lower and lower, more and more and more children live to grow up, but the ratio, the disparity, stays and still has not been addressed and still has not been erased. So that brings up a tremendous number of questions about the care that's being provided, about access to care, but also about the way that children are valued, but also I want to say about the way that mothers are valued. Because when we look at infant mortality and even child mortality today, what we're really talking about for the most part is newborn mortality. Most of the mortality, most of the children now who die under the age of 5 are dying in the first year of life, and most of those are dying in the first month of life. They're dying of causes related to prematurity, pregnancy issues, delivery. So really, if you want to talk about what's happening there, you have to go further back, not just into pregnancy, but into the lives of women and mothers, and into the kind of lives that people are living and the kind of health disparities that they face. So it's not by any means a simple fix, but it's a really important question.
I'm really struck by those numbers that you just quoted, not just for the racial disparity, but also where we are overall for the United States, because the United States, that's a vast improvement, of course, from 100 to 7, but yet compared to other high-income Western democracies, the US doesn't do that well, right? I mean, Japan, most of Western Europe, most of Scandinavia have lower rates of infant mortality than we do. What are we missing that we aren't yet doing quite as well as they are?
Well, universal health care is a good thing, not just for children, but also for adults and for parents. Prenatal care, making it as accessible and as high quality as possible, thinking about the nutritional status of people, not just when they're pregnant, but in their adult lives, thinking obviously about the impact of different kinds of stress. Yeah, absolutely. We don't do as well as other countries. And most people probably in my world would say, well, you would need to start by providing really good access to universal health care, not just to the children, not just to the mothers, but to the whole population, to the people before they're thinking about becoming mothers as well.
I want to stay with this topic just a little bit longer, because one of the things that you talk about so beautifully in the book is the power of the sanitary revolution of the beginning of the 20th century, this summoning of innovation, just this crazy burst of innovation in so many realms of life, like not just in medicine, but in urban planning and civil engineering and logistics and architecture, all combine to improve public health generally, to really sort of kickstart what we think of as public health in the United States, but specifically to improve the lives of women and children. I'm interested in sort of your thoughts and looking back at that, but I'm also interested, to give you the second part of my question at once, that I wonder if we need something like that again now, something like a second sanitary revolution to repair these profound social determinants of health that are so different across race and class in the United States.
We need something, and I mean, the first important piece that we need, I think, is to keep talking about it, to recognize it, not to accept it. I mean, on the one hand, obviously, as I would say to you, we should not forget to mark the victory of all of those hundreds and thousands and tens of thousands of babies and children who do live to grow up, who once would not have lived. We should never stop being grateful for the public health advances, for the parent advocacy, for the antibiotics, for the vaccines, for the newborn care. We should appreciate those, and we should never take them for granted, because that's I don't know how to say this, it's a kind of negative history, but there are kinds of suffering which go away. And it's not that common in human history. I mean, we don't seem to be able to learn lessons about, say, making war go away. But we made smallpox go away. And I was talking to a couple of my colleagues today. I've never seen diphtheria, a disease which I write about, and neither had any of my colleagues. And you know, there are sort of, whatever you want to call it, there are slices of human suffering which are eliminated along the way, and that's something to be tremendously grateful for. But on the other hand, there are these persistent inequities. There are these, and they reflect, they're not just numbers, they reflect larger inequalities, larger barriers, which you have to address. It's not just a question of let's make the numbers look better. It's a question of what's underlying this, what's getting in people's way, and how And very often, I think, in order to fix those, you have to start with the communities and ask them, what is it that would make care more accessible, more satisfactory, that would make people's lives better? I, the public health piece is really inspiring because, as I was saying about Josephine Baker, a lot of these really dramatic improvements come before you've got high-tech neonatology. And you need high-tech neonatology to get to where we are today, because as I say, many of the deaths we still have are still neonatal deaths, and they reflect prematurity and congenital anomalies and problems that come up early in life. But those great big advances happen really based much more on hygiene, on clean milk, on breastfeeding, on clean water, on sanitation, on being able to handle the sewage in the city. Problems which you can fix without the super science.
I have a couple more questions for you, but we're running toward the end of the hour, and we do have a couple of questions come in from folks who are listening. Thank you all. You're very welcome to send in questions still. So I'm going to say these out loud so everyone who does not have access to the Q&A can see them, which is first, the person who was having trouble with his sound, but fortunately is back. Thank you, Jonathan. Says that everything that you're saying about the improvements of public health, separate from sort of, the high technology, reminds him of the prenatal nutrition program WIC. And he knows about this because his mother was a public health doctor in Connecticut and brought WIC to Connecticut. Is there anything that you want to say about a focus on nutrition specifically, or about the government ensuring the nutrition of women and children as part of this public health improvement that you talk about?
Well, I think a lot of that actually goes back to that moment in the 1920s when you were calling out the American Medical Association. But when there is, for a brief shining moment, a federal children's bureau, and the federal government actually gets in, they're interested in the question of preventing child labor, but they're also interested in the question of providing people with nutritious food. There's a tremendously strong and complex movement to try to purify the milk, because milk that's being sold, especially in poor neighborhoods, travels a long way, often goes bad, is often adulterated, not with clean water or with anything that should be in it. So I think that public health, that nutrition approach, that idea that the milk needs to be safe and that people need to be able to keep it safe, that's probably, it's the very, very important, very, very big first step before we get to antibiotics to cure infections if they get them. Because it's obviously much, much more practical to prevent them from getting those infections. Pediatrics is an incredibly prevention-focused field, right? We would like to immunize everyone against measles and never treat a single case. We would like to immunize everyone against diphtheria and never treat a single case. We would like to see babies and children, eat a healthy diet growing up and not deal with the impact of malnutrition.
So another question that's come in from the audience is, well, the writer acknowledges the enormous improvements that you're talking about, but is curious why there does not seem to have been that much improvement for the problem of miscarriage. And she's speaking as someone who actually had a miscarriage herself, though she still has, she has surviving children, and her mother also was the survivor of the miscarriage of a twin. Is there anything you want to say about miscarriage as a particularly gnarly problem, or something that poses unique difficulties?
Well, what I want to say first is that I'm a pediatrician, and I'm probably not the right person to speak medically about the issue of miscarriage or preventing miscarriage. What I will say is that many people have written and thought about the ways that our relationship to pregnancy has changed with the increased access both to information. People generally often now know that they're pregnant very early. And also with the ultrasounds and the ability to sort of watch fetal development in more detail, there are many people who think that both the understanding and perhaps also the emotional connection that people feel during pregnancy may have evolved and changed, and probably in ways that medicine may not always have kept up with in terms of being able to address the emotional content. I would also say, going back, that this is not about preventing miscarriage, but it's about coping with miscarriage and pregnancy loss when it happens. This was an area in which doctors were not particularly good at. If I did look in the literature to look at the sort of the psychiatric literature and the literature of how you address loss in the delivery room, stillborn babies, miscarriages, and this is something where you really look to the advocacy and the voices of the women themselves saying, this needs to be taken seriously, this needs to be recognized, this needs to be marked. I realize that that's not necessarily the medical question that you're asking, but I don't think I know the answer to that one.
So let me tell you what my two last questions are. We're running up to the top of the hour. Not that this is going to wink out of existence. We can keep it going if we want. The first is, you, of course, were finishing up this book in the midst of the COVID-19 pandemic, the largest public health crisis in more than 100 years. In fact, you managed, and I'm incredibly impressed by this, you managed to mention COVID in your introduction. So your editor and publisher must have been very kind to you in letting you get that in at the last.
Yes.
It was very wise. So, we've seen not only the devastation of the pandemic, but the extraordinary global scientific response. And I wonder if there's anything, looking through that lens, that that you can say about, sort of what it looks like when we make an absolutely full court press on something, and is there any relevance to the continuing problems of infant and child health that the COVID response tells us what we might be able to do? That was a very difficult sentence. I'm sorry. I apologize.
No, I think I understand. I'm gonna try answering it in three different ways. So the first is that COVID reminds us of vulnerability. I started medical school at a moment when there was a sort of legendary speech that somebody made the first week about basically infectious disease is over. We've won that battle. It's like the sunny day at the beginning of the horror movie, because of course HIV was about to happen. We were about to start reading those stories, and that would be kind of one of the dominant medical narratives of my training years. But that first week of medical school, we heard about how our job would be to take care of the chronic diseases of civilization: heart disease, lung disease, infectious disease. That was conquered. So I think that, and it's not unique to this pandemic, it was also true of HIV, it's been true of many other things. We do get reminded periodically that we exist in a complicated, interlinked world, including a large and not well-known microbial. They're here with us, and we interact with them, and we have to be humble and learn what we need to know. The second thing I would say is that I mean this book, even though it's got a lot of dead children in it. You should have heard me trying to explain to the editor, but it's really a happy story. It has a happy ending. I mean, this is not a book about a single smooth crusade, a single smooth, you can look at polio and you can say, we decide to take this on, science and public health and the parents of America and the March of Dimes, and we march together. This isn't ending infant and child mortality or reducing it or defeating it or battling it. It's a lot of stuff mixed together, science and public health and, public campaigns and education. And some people you probably don't want to find yourself marching with, and some people you're surprised to find yourself marching with. It's a lot of different pieces that takes us down this trajectory. So I think there is a lesson there about not necessarily expecting things to go always in a obvious, planful way, and being willing to credit the different kinds of human cleverness and ingenuity, and being willing to combine elements from a lot of different areas. And then the final thing I will say, which is the moral for me of this book, is that you do not make the world safer for children by making your own house perfectly safe, which is something that cannot be done. And if you start thinking of, I am going to childproof my house, and I'm speaking I don't just mean really childproof, if you mean my child will be perfectly safe, it doesn't work. The way you bring down infant and child mortality is you make the community, the city, the country, the world safer for children. And then everybody is safer. And I think there is a message there about public health and the ways that we are linked together, and the ways that we keep children safe by making the world safer for all children.
That was marvelous. Thank you. I'm going to ask you my one last question, precisely because you said that you were saying to your publisher, but this is a happy book, which is true, because it's this incredible story of this, though not steady, still an overall upward trajectory in the improvement of public health for infants and children. And I think what I want to ask is, does that trajectory keep going? Can you see that is it an endless upward curve, or have we done about as much as we can, or do you look forward to more?
Oh, you look forward to so much more. And you look forward to more in a couple of ways. We would start with the disparities. We would say whatever is the best we can extend, the safest we can make it, that should be extended to all children, and we should figure out how to do that. But then we look at what is still dangerous to children. I'll mention gun violence, I'll mention other kinds of violence and safety issues, but I'll also say, what are the stresses and difficulties? And as the world changes, those change as well. I'm a pediatrician, I'm also a parent. At the beginning of the 20th century, the world decided that the infant mortality rate was a good index to how a society was doing, because it was a number, if everybody counted it the same way, which gave you a look at how your city, your country was doing in taking care of its most vulnerable citizens. And I think that an index of how children are doing, whether they're thriving, whether they are growing and developing in a good way, is still a very useful index to how a society is doing. And I'd like to see us figure out what the best index or indices are, but I think it is part of the way we take our own measure.
I like the idea of a children's index. Let's hope for that. Okay, we are out of time. Dr. Perri E. Klass, thank you so much for speaking to us here in our author Q&A series for the Emory Center for the Study of Human Health. Thanks so much to all of our participants for joining and for asking such smart questions and for staying until the end. I'll just tell you again, the book is A Good Time to Be Born: How Science and Public Health Gave Children a Future. It's fantastic. Please go out and buy it. And please come back next month when we talk to Chelsea Wald about her book, Pipe Dreams, and the global evolution of the toilet. Thank you all for coming to listen to us. Stay safe.